Hello, everyone. Welcome to our presentation on Imagine Safe Supply. First and foremost, we need to recognize that our research is carried out with the Canadian Drug Policy Coalition located at Simon Fraser University, which is on the unceded and traditional Coast Salish lands, including the Squamish, Tsleil-Waututh, and Musqueam nations. Further to this point, we note that prohibitionist drug policy is an active and ongoing arm of colonialism in Canada. And we start from the understanding that notions of safety may have different meanings that are nuanced and specific to First Nations, Indigenous, Métis, and Inuit peoples. Through partnership and an openness to learning, we work with the intention that safe supply can become a meaningful part of reconciliation where there is interest and need in this, and that this requires our transparency and commitment. And another note, we use the terms drug users and people who use drugs interchangeably in this presentation out of the recognition and respect for the people that we spoke to with their various personal choices on how to be referred to in their identities. Next slide, please. The principal investigator for this research is Donald McPherson, and the research staff at CDPC include our graduate research associates, Karanveer Pada, Jack Farrell, and Shauna Callahan, and our senior research associate, Erin Howley. It is co-led by us, the community research associates, Celine Cote, who's joining us today. Yes, they do look very similar. Frank Critchlow, Erica Schoen, and Mickey Schell, as well as myself, Phoenix Beck-McGreevy. The Research Advisory Committee includes Dr. Alyssa Greer, Dr. Marie-Ève Gaulier, Dr. Elaine Hishka, and Dr. Jillian Kola. So our research question, what we set out to ask was, what are some of the attitudes and perceptions about participation in safe supply, both for people who use drugs and the frontline workers who directly support them? And we really we want to thank you all and those of you who generously offered your perspectives and your input into this research. We've worked really hard in our data analysis to reflect the integrity and transmute the knowledge of all of our research participants. As I said, our research question asked about attitudes and perceptions about participation in safe supply. And in this research, we consider safe supply to center the choices of drug users and to be different from models that focus on reduction or abstinence of drug use. So we wanted to hear about the gaps between the current access to a regulated supply of drugs, which could include OAT, IOT, and stimulant replacement therapy, and what people desired from a safe supply. Okay. I'm going to pass it on to Erin now.
Okay, great. Thanks, Phoenix. So we recognize that access is unequal from province to province, urban and rural. This is important to keep in mind, and we heard about different levels of access in this research. The overall data set included 55 key informant interviews. 40% of the data was First Nations participation. The research is taking place through a partnership with Thunderbird Partnership Foundation, which is stewarding and leading data analysis of First Nations data under OCAP standards. This presentation pertains only to the non-First Nations data, which includes 33 participants from across BC, Alberta, Ontario, and Quebec. The recruitment criteria were that people used opioids or stimulants at least once a month for the past year, or that they worked at least 10 hours a week in frontline work, formal or informal. So that could have been volunteer or formal hired positions. 70% of the participants identified as both a frontline worker and a drug user. So a strength of the data overall is in this overlap between people who are accessing safe supply, as well as the people who are working in the care and service settings. And that's important because the frontline worker experience, I think, is often overlooked in safe supply. This chart shows the participants' drugs of choice for those who identified as drug users. Stimulants, opioids, and benzos were the main drugs of choice and of concern as relates to safe supply. Participants who qualified to take part as frontline workers indicated they had a range of roles, including harm reduction, peer support, outreach, shelter and drop-in work, crisis response, and street or community nursing. We sought to speak with people across a range of urban and rural locations. So 25% of the participants lived in towns under 100,000. 33% lived in towns between 100,000 and 1 million, and about 45% lived in cities of over 1 million people. Just under 58% of the participants were female cisgender. Just over 39% were male cisgendered, and 1 participant identified as gender fluid. Participants further identified as unhoused, Black or Afro-Caribbean Black, people of color, LGBTQ Two-Spirit, and Indigenous Métis within our intake survey. In keeping, the data reflects demographic findings for these subgroups, and we also heard from people who identified as sex workers and parents, including findings around the needs and importance of cultural inclusion within safe supply for these groups. The majority of the participants were between 30 and 49 years old. 18% were 29 or younger, so identified as youth. 30 were 30 to 39, 33% were 40 to 49, and 18% were 50 and older. (15 or 45% of the participants had some experience on agonist replacement therapy. All 15 of these folks had been on OAT, or opioid agonist treatment. Some of these participants had also been on IOT or stimulant replacement therapy in addition to OAT. And then 39% of people in the research had experience with non-agonist prescribed safer supply. And 21% said they had some experience with buyers clubs or non-prescriber mediated models. And I'll pass it off to Jack. Jack, we can't hear you.
Thanks, Erin. I think Phoenix is actually taking this one.
Yeah.
Oh, yeah. Sorry,
yeah.
Phoenix. Sorry, that's yours, Phoenix.
Sorry, y'all. So first, we'd like to discuss values, which were understood by the team to be beliefs and norms that inform our actions and that are part of drug use culture and relationships. These were incredibly key. They form a lot of our findings. We heard a lot about the values that people held and that their communities held. And no matter what the Safe Supply Program model or service, we can trace it back to a set of values. We heard a lot of detail about the following value systems for safe supply that was desired by our participants. One was community and relationship building. Another really key one was autonomy and self-determination. Culture inclusion, mutual care, and trust were all spoken of very, very consistently by our participants. So I'm going to move on to the next slide with community and relationship building. So we heard from our participants that people who use drugs don't often have a lot of spaces to be with each other, and that safe supply should offer ways for people to come together. Connection and community is central to drug use culture and is connected to a sense of empowerment. Next slide, please. So some of the things that we heard about community and relationship building from our participants are shown here. So people are aching for a sense of community. If we had a safe supply program that creates relationship, I think that's a huge thing that's missing in a lot of stuff, right? Everything is so clinical in regard to substance and substance use approaches. The next value is autonomy and self-determination. And this was discussed by our participants as both being a personal and a collective value. It's connected to the ability to make choices about people's own needs, preferences, and their interactions with others. And autonomy is in opposition to criminalization, surveillance, and gatekeeping. It means asking people what they want rather than telling them what they need. In other words, allowing them to make decisions without coercion. I'm sorry, my cat is being really needy right now. So in regards to autonomy and self-determination, one participant said, we should be empowering people who use drugs to make self-determinations in what's best for their lives and their communities. They said that they don't want to be here to make decisions for you. They're not here to tell you what to do. They're here to witness your truth and help support you in what that might mean for you. And cultural inclusion was another incredibly important value. This involves consideration around people's religions, gender norms, the protocols for communications, the roles that their family takes, how to include mentorship and elder relationships, taking consideration of class differences and things like immigration status. Cultural inclusion is necessary for addressing the racism and other risks for groups that are extremely marginalized within and outside of Safe Supply. Cultural inclusion involves creating leadership and staffing that is representative of the communities that are being reached by these programs. One participant said that if doing this sort of thing, we have to be culturally appropriate in understanding a couple of things. All Black people are not homogenous. We are not monolithic. Someone is from Trinidad. I'm from Jamaica. We're both from the Caribbean. We both have similar outlooks, but we also have major differences in how we think, how we do, and what we process. Mutual care was incredibly important to our participants as well. We heard that Safe Supply access would feel emotionally safe. It would be non-judgmental. It wouldn't be intimidating. It would be caring, compassionate, empowering, and it would be destigmatizing and would take a non-punitive approach to people's lived realities. Mutual care relates to feelings of being valued, being loved, and making meaningful contributions, and doing this with a deep attachment and a responsibility to drug user communities. Shared experiences and identities are an important part of mutual care. One participant said, I'm a substance user, and this is how I contribute to my community. This is what I have to offer. I have value, I have connection, I have community, and I'm loved, right? I'm worthy. The last key value that we heard about was trust, which is based on long-term and established relationships. In other words, it takes months and years to build. Consistency and dependability are important to trust. The consequences of a broken promise or a breach of confidentiality were seen as extremely profound and very alienating. This can be addressed with representation from the respected community members and including these folks in these sorts of safe supply models is an incredibly important piece of building trust. Regarding trust, one of our participants said, the people involved in distributing Safe Supply need to have shown that they will continuously show up for people who use drugs. This isn't because of a job title or a new Safe Supply program. People that are invested in community and people who are invested in people that use drugs in small communities already and that have that trust and relationship built. And I'm going to pass it to Celine now for best practices.
Hello. So the best practice that people were saying is, wait a second, leadership and decision-making, personalized care, attention to confidentiality, ease of access, low barrier, and community specific.
So our findings suggest that current access to Safe Supply isn't working as well as it could. We heard people talk about how drug users are often expected to fit into a box of criteria and expectations in order to access safe supply. This box is about who is excluded and ignored because of racism, marginalization, and stigma, as well as the pressure of what's being expected of them. A lack of capacity around current services and the pressure this creates for people who use drugs is also part of the box. So how can we improve participation in safe supply for people who use drugs? Our findings suggest that we can improve participation and inclusiveness by designing safe supply in line with community values. We propose that this alignment with the values of people who use drugs is important for their participation. While we heard about a core set of values in this research, these could vary from one community to another in ways that are culturally specific. And when designing safe supply locally, we can ask what drug user values would look like in practice. We heard about some core elements that would make up safe supply programs, including drug options and dosages, locations, personnel, dispensing, or how the drugs are given out, and the services offered. So let's take a look at what people said about their current experiences for each of these aspects of safe supply design and what would help improve participation for drug users. And with that, I will pass it off to Jack.
Thanks, Erin. So first, we're going to look at what people said about the current regulated safe supply. I actually think a slide may have been skipped there.
Oh,
Yeah, there we go. Great. So other than methadone and Suboxone, hydromorphone was the most frequently mentioned drug, sometimes prescribed alongside with methadone or Cadian. However, when prescribed with methadone, there was often an expectation to reduce or discontinue hydromorphone use. Stimulants were mentioned much less frequently than opioids, and stimulant prescriptions were mostly about stabilization of mental health in connection with psychiatric diagnoses. In terms of what people desired for their drug options and dosage, we heard overwhelmingly that fentanyl was the most requested opioid, followed by heroin. And people were finding that alternatives to these drugs were not strong enough and did not match the desired high. In terms of stimulants, cocaine was the most requested, followed by methamphetamine. And very importantly, the lack of stimulant options was mentioned as a major limitation of safe supply. Furthermore, there was a desire for opioid and stimulant co-prescriptions. And applying this to the values that we spoke about already, choice of drug options and dosage falls under the value of autonomy and self-determination. One person noted that the more choice is offered, the more likely safe supply programs are to be effective. And we heard there was a desire for safe supply dosages. No, back to the, that was good. Yeah, thanks. We heard there was a desire for safe supply dosages to be guided by the needs and decisions of the people using drugs. However, a lack of choice around drug options led to less open conversations with prescribers. It also meant that people are often self-managing their doses in combination with the street supply. Some people saw reduced dosages to be the result of prescriber fear of diversion as a punitive measure. Generally, there was a limited discussion around client ability to renegotiate dosages with doctors. And as a point of discussion, there can be a fear around being cut off a prescription. If a person isn't getting what they need, they may end up using the street supply. If this is treated as punishment or treated through punishment in terms of being cut off, this increases the risks they face to overdose. Okay, and we're going to make a brief note on the concept or the wording of diversion as this is often a concern for prescribers in safe supply. However, we made the decision to reframe this term, and instead of using the word diversion, to use the term sharing and resale. And we made this decision because the word diversion is often used specifically in clinical settings and also can be very stigmatizing. Instead of seeing this practice as negative, we want to look at the reasons why sharing and resale happen and what would be some of the way of thinking about solutions. So many people had experienced policies that were meant to stop sharing, such as restricted carries, observed dosages, or the expectation to taper drug use. We heard that when these policies were enforced without mutual conversation about a person's goals and wishes, it felt coercive, limited autonomy, and undermined person-centeredness. Some people thought fuller socio-economic supports and universal access to safe supply would reduce people's needs to share and resell. Furthermore, by sharing, people often supported their communities to get access to safer drugs rather than relying on the toxic street supply. Sharing and resale allowed people to get access to safer drugs when it was not possible to find a prescribing doctor or to enroll in a safe supply program. Sharing and resale also meant that people could still access safe supply when they couldn't manage to pick up prescribed drugs, though an issue was that the available dosages could be changeable from day to day. People also discussed the role of prescribed safe supply programs themselves in driving and causing the sharing and resale of prescriptions. This might happen, for example, if programs didn't sufficiently meet the needs around drug options, doses, and access, and if they don't include poverty reduction supports, such as housing or food security. Although sharing and resale is often painted as a patient problem, people saw that it connected to safe supply retention and as a value of mutual aid. Several people, for example, spoke about how shared prescriptions are a way to support their communities to overcome barriers to safe supply access. For example, if someone can't pick up their prescription, they can still get regulated doses and stay in a program instead of turning to a street supply, which in the current context, it could be deadly. People also talked about how sharing and resale opens the door to safe supply access for communities that do not yet have it. In this sense, drug sharing can be seen as a temporary band-aid solution to help increase access to existing safe supply. Shared prescriptions could be seen as a way of community caretaking that is aligned with drug culture values of mutual aid and support in a time of crisis. Drug sharing was talked about as an immediate step that can be taken to help address the toxicity of the unregulated street drug supply. So we can look at resale and resharing or sharing as positive, life-saving interventions and not as a negative behavior. How could this perspective help make drug access more collaborative and community-based? So we kind of return to the first point about why we actually changed from calling this practice diversion to sharing and resell. And that's because so-called diversion has the effect of blaming drug users for what are really systemic problems. We can reframe diversion as a problem about the matching of drug options and dosages rather than a problem with the person. In this sense, this practice points to gaps in drug policy around drug options and dosages. And in order to reframe this problem, We can look at sharing and resale through the lens of community values, such as autonomy and mutual care. We can also use this viewpoint to give us perspective on the role of community networks for safe supply education and uptake. Effective safe supply is a community effort. Furthermore, the local drug preferences, strength, and toxicity is really important to consider because it varies between communities. This is an area where drug user input into drug options and dosage would be essential for different programs across the country. And we have a quote here from one of our participants. But people are hooked on fentanyl. Why are we giving them 7 new drugs and not fentanyl? Now they're out hooked on a bunch of different things, and then they're still out getting fentanyl on the street. It's incredibly clear to me that we give people what they want. So I'll pass back on to Erin now to chat about locations.
Thanks, Jack. So our next topic is locations. There were a number of desired locations for safe supply mentioned in this research. A one-stop shop would include an array of holistic services available all in a single location. These spaces were described as a drop-in center in which everything you could need from harm reduction would be available, or would provide community healthcare, housing, and counseling services all in one location. A one-stop shop could provide for confidentiality depending on the range of services offered at the site. A mobile safe supply program would provide directly to homes or move around within a radius to increase accessibility. A benefit is that people would have more choice about avoiding physical sites or personal interactions that they don't want. Medical settings such as a clinic or hospital were discussed with hesitancy due to healthcare stigma, but it could offer immediate healthcare follow-up for people with high health risks. In rural areas, community healthcare settings were discussed as a more likely clinical space. And the Compassion Club model is designed, implemented, and led by people who use drugs. A commentary on this is that some people in this research did talk about buyers collectives where they get drugs sent through the mail, and this could be seen as an intermediary to compassion clubs in the absence of a federal exemption to the Controlled Drugs and Substances Act. Mail access might be also more feasible for rural areas. The benefit of providing safe supply out of a harm reduction site, such as a needle exchange, OPS, or supervised injection site, include the pre-existing relationships with staff and the ease of being referred to services. Other settings that people mentioned that they wanted to see included dispensing machines, integration with housing programs, and retail locations. Virtual prescribing could be of really interest to rural communities, but this was a gap in our data. We didn't really hear a lot about the virtual options or why those are important. So that could be reason for further follow-up. It's important to consider needs for access and hours of operation, especially in relation to transportation and access barriers, because this all could affect the trust in a program. We heard about confidentiality and anonymity concerns, especially in rural settings, around a lack of safe spaces for people who use drugs and the potential of really pronounced and targeted local stigma. Generally, people mention multi-purpose or health program locations as a strategy to protect the confidentiality of people receiving safe supply by hiding the purpose for visiting the location. And a discussion point, the notion of a one-stop shop of holistic care combined with mobile service could be a really great solution to provide for confidentiality. And some quotes that share a little bit more about locations. The stigma is very, very real. And if they, they tell their neighbors, oh, I saw so-and-so wherever, picking up their methadone, and yeah, it's nobody's business. But if you're picking up methadone or safe supply or anything else, people absolutely talk. These small tidbits of information travel really, really fast in small towns, and it can mess people up in a variety of ways. And word gets out that you have a prescription for morphine or Dilaudid, what have you. I mean, that could be very problematic for your family. So I would say absolutely, it's of utmost importance for confidentiality always. Generally, people mention multi-purpose or health program locations as well as home delivery as a way of protecting confidentiality for people receiving safe supply. Overall, the attention to geographic and culturally specific confidentiality is an important aspect of safe supply access. Excuse me 1 second. And I find that most rural clients or people that use drugs, they're okay with going to those health center buildings. And maybe there's room off the side or something, where somewhere private and discreet, where not everyone underneath that roof needs to know your entire business or why you're there, but it's for them to go. Okay, and I'm going to take this next section as well. So this section is about personnel. People with lived experience can be seen as the most important personnel at safe supply programs. This is what we heard over and over and over again when we asked people who they think should be leading and staffing safe supply. Lived experience was important to overcome barriers of the medical system, such as lack of trust, stigmatization, and judgment. So there's different roles that people talked about drug users having within staffing. These included health navigators to liaison with medical providers and health authorities, enrollment and intake guides, people to discuss your needs and desires and supports that you want to see, and to help actually run the programs and activities in education. People stress that lived experience should be a priority in all stages, from program design to operation and evaluation, and always paid at the standard professional rates. People generally wanted other drug users to be leading the program, and if prescribers are involved, they would have a more background role. Nurses were the most desired medical practitioners, especially those who've worked with people who use drugs and have training in harm reduction. They were seen as easier to relate to, less judgmental, and more compassionate. Here's a quote. "It would be ideal to have a harm reduction nurse, complete with the language and attitudes and the vibe. They would fit seamlessly into this. They're like our biggest allies here. I've never met another professional community that isn't so on board with preservation of human dignity and human life. All those nurses, that would be very cool. Yeah, a hip nurse and peers, that would be the ideal setup." For those who desired interactions with prescribers, they wanted it to be inclusive, curious, compassionate, non-punishing, empathetic, and collaborative. Positive prescriber relationships generally center the needs of people who use drugs, making deliberate efforts to accommodate a person's unique circumstances. People felt that prescribers often oppose or discourage drug users from experiencing pleasure, and this was the main problem we heard about in prescriber relationships. That has a serious consequence for the capacity of prescribed safe supply to meet the needs of drug users. Power imbalance between people who use drugs and prescribers drives that antagonistic relationship, or like we were talking about before, the box that people have to fit in. And that just reinforces the need of drug users to have to audition for their care, or prove that they deserve safe supply. You want someone that's going to be supportive and non-judgmental and compassionate. I wouldn't want to just invite anyone to prescribe safe supply. Trust is a main value that guided discussion about the quality of desired personnel. We heard that trusted relationships are really important in rural areas where stigma and targeting can lead to confidentiality and safety concerns. And as a point of discussion, there can be hesitancy to take part in programs because of the potential lack of continuity. For example, if there's a funding cut or building closures. Rurally, I think that people who have relationships, already established relationships with service providers that they trust, I think that's what's crucial when considering rural. The people involved in distributing safe supply need to have shown that they will continuously show up for people that use drugs. And this isn't because of, a new job title or a new safe supply program, people that are already invested in people that use drugs in small communities already, and that they have that trust and relationship built. So our recommendations are that there's currently a great deal of criteria for people who use drugs to access and stay on safe supply. Right now, people who use drugs kind of have to prove that they need it and that they deserve to be on it, is what we heard. On the flip side, there can be positive criteria for prescribers so that safe supply is in keeping with community values and maintains those trusting relationships. Having a two-way street of criteria for both doctors and drug users for collaboration and involvement could be a pathway to address unequal power relationships. With the premise that safe supply can be rooted in drug user leadership and decision-making, it's important to consider accountability of prescribers and those service delivery personnel. What would prescriber accountability look like to you? Off to Jack.
Thanks, Erin. So far we chatted about locations, desired location and desired personnel. We're going to chat now about desired routes for dispensing in safe supply. We heard that people wanted to see flexibility within policies for pickup and delivery, including individualized approaches, various options for pickup, freedom of choice and movement, and to not be kicked off safe supply if they miss picking up for a couple of days. People were fairly split in favor and opposed to witness doses. Ways we heard to make witness doses more acceptable included involvement of outreach workers, requiring witness only for specific cases, and only for the first dose of the day if necessary. The most frequently mentioned methods of desired dispensing of prescribed safe supply was from pharmacies and through delivery. We heard that pharmacies would be easier to get to than a single or centralized pickup location. Furthermore, delivery through mail was mentioned as a way to protect confidentiality. People also discussed at-home delivery, saying they would be more likely to participate in safe supply and that it would be more effective in rural settings, particularly in rural settings. And to talk a bit more about rural considerations, we heard from rural participants that their local community lacked the basic infrastructure necessary to support a safe supply program, such as a pharmacy or supportive prescriber. For example, not having access to a personal vehicle, having mobility issues, or extreme weather worsened rural barriers to drug access. So home delivery in rural areas may be the best strategy to address accessibility and stigma barriers. Furthermore, reliable and adequate carries are also really important considerations to overcoming these barriers. So in this quote, an individual had to rely on hitchhiking to pick up a dose. I mean, it takes me 3 or 4 hours just to get out of the bush and hitchhike to town to pick up my dose. You're really at the mercy of the world, right? So, I mean, with the COVID thing, it's tended people to not want to pick people up on the side of the highway, right? A lot. So in some cases, the difficulty of drug access for rural participants meant they needed to return to the street supply. There are also reports of liability concerns restricting drug delivery without a plan for follow-up. We're actually not allowed to distribute the safe supply. Whereas we were actually picking up people's prescriptions from pharmacies and delivering them to them because it's a very rural area we live in. And we were picking up the prescriptions and driving it out there until our executive director caught wind of that. And she was like, yeah, this opens up a whole can of worms for liability, so we're not actually allowed to distribute anymore. So strategies to address liability concerns around transport and delivery is a really needed area of attention, in particular in relation to rural areas. This quote now reflects an alternative frontline workers' viewpoint around hesitancy to deliver. I felt like, yeah, people were really grateful to be able to have their drugs delivered. But it did feel a little bit strange at times, just because the liability issues. Like, drug users can be unreliable. Drug users at times can be like, no, he didn't give it to me. I didn't get my full dosage, things like that. I'd actually like 2 people to come. I'd like the drugs sealed in containers from the pharmacist in blister packs, things like that. Okay, and I'll pass it on to Erin to chat more about support services, desired support services in Safe Supply.
Thanks, Jack. Some of the most frequently desired supports for Safe Supply were harm reduction, especially supervised consumption, overdose prevention, and harm reduction sites. So this harm reduction context was really important. There is a desire for easy access to comprehensive health services, and that includes treatment and withdrawal supports. There was some mention of interest in a cooperative health network across Safe Supply programs, likely that would be provincial, and that Safe Supply be coordinated across health services, such as family care and hospitals. However, at the same time, data breaches was the #1 confidentiality concern that people mentioned in this research. The idea of going to a doctor or health center and having your drug use be shared around was really cautioned against. The integration of health services with Safe Supply would need to address choices around personal health records. People described housing as essential in connection to Safe Supply. They imagined it being combined with housing access and support. And there was an interest in education and training by people who use drugs, namely safer drug use, life skills, self-care, and cultural offerings. A focus for mental health was culturally representative counseling for diverse people, 24/7 emergency mental health care, and trauma-informed approaches with peer-based emotional support. So those were kind of the main wraparound supports we heard people wanted. Off to Phoenix.
So as you can see, effective Safe Supply involves drug user leadership from the top down. So Safe Supply should be considered a process of drug use community leadership with opportunities for health sector and frontline service collaboration on strategy and evaluation to build this leadership. We just presented a number of program values and components, and these should be considered as evolving pieces of regionally specific Safe Supply models. It's possible to develop and innovate on these pieces over time in connection to building that drug user leadership and feedback. Our takeaways are on the screen there. Some of the brief takeaways include incorporating the community values of drug users within the Safe Supply program design and the evaluation, ensuring that drug user leadership in all stages of planning and operations is a foremost concern, and considering regional and cultural specific models based on local needs and drug use patterns. Some of the considerations include these questions that we came up with, which could be used to apply what we've learned and our findings to the local Safe Supply program design and evaluation. So one is, how is this program based on inclusive processes for feedback? How can these processes be improved? How does it create options for confidentiality and trust? How does it respect the rights and needs of people? How does this program prioritize drug user leadership, organizing, connection, and community building? And in what ways, if any, does this program center cultural inclusion? Some further considerations. How does this program respond to the different reasons that people use drugs? And how does this program address the existence of racism and discrimination? How does this program involve personalized and collaborative approaches to confidentiality and personal safety? And who leads it? Who's working there? What is their level of decision-making power? What is their relationship to the local drug user community? In considering that, what are some of the local patterns of drug use? Like, what are the drugs of choice? When do people want to access them? What strengths do they want? And how does this lead to creating pathways for mutual aid? And what are some of the methods that this program can use for raising local awareness for drug users around their eligibility for safe supply and how to be involved, their intake processes? And finally, what forms of provincial and federal advocacy are needed around safe supply to increase the resource distribution and make policy change? I'm going to pass it to Erin to close.
All right. Thanks, Phoenix. Thanks so much. Thank you, everybody, for taking the time out of your day to listen to these findings. It's been a labor of love and a lot of hard work. We've been at this for 3 years now, which who knew it takes that much time and effort to do a research, but we really sought to give a lot of care and attention to the interviews. You can contact our team at this email address, research@drugpolicy.ca. Also, we're working on developing our knowledge sharing resources, which we're going to be sharing on a website within the upcoming weeks. And that will include a really cool zine publication that you can download and print or just look at online as well. So we'll be back in touch to let you all know when the website's published, and you can take a look at those materials there. Okay. So thank you all for taking a listen. Right now, what we'll do is just open up the floor for question and answer. Really would be glad for your thoughts and your feedback. And it looks like already there's been a number of questions in the chat. So I'll just open it up first for if anybody wants to raise their hand. Otherwise, we'll start with the chat. Great. Charlene.
I'm just curious if there's any vision on how this information could influence all of the work that's being done around safer supply models, policies and frameworks and workbooks and all those other pieces. Just thinking about MMHA's recently halting those meetings, and there's so much rich information here that really, as what I've been hearing for years as well around safe supply. And I'm wondering how this research and data could influence those working groups to ensure that the policies and models and frameworks and other pieces that they're working on are influenced by, people with lived and living experience and what you've heard through this data, but also recognizing the importance of having people with lived and living experience at those working groups at the table in live sessions as well. But do you think that there's a way that this can or will be used to help to inform?
I'll take a go at that quickly. That's our ultimate hope, Charlene. I mean, we really, really dug in to try to do justice, like I said, to all of the dozens of people we heard from. And in context of CDPC, hopefully there's pathways and lines of communication, for example, with the Minister of Mental Health and Addiction, provincially and even municipally. Our knowledge sharing priority was to reach drug users and frontline workers and those organizations like those of you here who helped us do this outreach. Because one thing we heard was, especially in like rural areas or where there's not a lot of drug user organizing already, the level of familiarity with safe supply was less. And until people have that knowledge and can feel empowered, that's one of the first steps. But our knowledge sharing is meant to reach prescribers and pharmacists and policymakers. So we do hope to make these things, to have these things enter into those conversations. And I think it's so true, Charlene, too, that a lot of this stuff is not new under the sun, but we've been hearing about all of this for such a long time. But hopefully the research format and the very rigorous methodology of community-based research that we used here can help formalize it so that it can be taken up. We've already shared these findings with Health Canada, and we hope to really continue reaching those federal and provincial levels. I think Chanel had a question. Chanel, did you want to jump in here?
I did actually, and just at the tail end of there, you had answered that question. So it goes to what Charlene was just speaking to about open channels of communication, and you just at the end there answered the question that yes, indeed, Health Canada was aware of the findings of this research project from Simon Fraser University and CDPC. And so I guess what I can commit to myself is just helping to also reiterate back to them, hey, I also, by the way, have you seen this amazing presentation from you guys? And so that will be at the top of mind in my next conversations with Health Canada too. But I just really thank you guys, because I don't know if this is allowed, but I was screenshotting all the way. It was just so much, because I'm just going to go through and read back, because it's just all such really good quotes that we've heard from people. And that's really what needs to be reiterated back to folks, is this is what the community is saying. And so, yeah, thank you. You did answer my question. And thank you, Charlene, too. I appreciate you.
Fantastic. Thanks, Chanel. Sue.
I actually got the answer to my questions, but I guess the question I'd like to say to you is, how can I help get this information out there as a person with lived experience and an outreach worker? So how can I get this information out there? Because it needs to be out there, so it's needed,
You can share our zine when it's published, and the rest of our findings. We'll be having a project launch where our findings will be available, so we'll make sure to get those information links out to you.
Yeah.
Thank you so much. Thank you.
Yeah, there will be a website, and the zine is going to be beautiful. Very artistic, and very much for other drug users and frontline settings. So the thing about the zine is that it includes prompts for dialogue. It lets you kind of consider and answer questions for yourself or with other folks. It gives you a way to start a conversation. And the more conversations that can be had with the level of rigor that comes from all of the work and interviews from this project, then hopefully people can carry that back and assert their needs and interests to, those health authorities, to the organizations, and to the politicians. Okay, so I'm going to jump into some of the chat questions. One question so far, again, and this again was from Charlene, but there's only one overdose prevention setting in Northern Health in the Northern region. I don't see anything about drug user organizations as an option. Charlene, just a question, was that in regards to like the settings for the safe supply?
Yeah, I think it was in regards to settings, but my apologies. I also came in a little bit late. And so I missed part of the presentation as well. But I think this is a piece that's really important when we're thinking about, how to roll out models like this, and really thinking about rural and remote and on reserve as well.
Yeah, in terms of the site where it's taking place. Yeah, I think the thing that really speaks to that, and I'll toss it off to the team as well, is that the drug user leadership was central. When we heard about a one-stop shop, we could have probably clarified in the presentation, that was drug user led largely. One idea that we heard over and over again was the idea of a house that people come to that's just like a safe supply house where you would sit down on the couch, watch TV, take a shower, see the people you know. And it all comes back to the values that we talked about again, Charlene, at the beginning of the presentation. We heard about community values for safe supply. So trust, mutual care, community and relationship building, cultural inclusion. That was really the premise that we heard, is that these are drug user-led initiatives. So if there are health authorities or prescribers or people involved, there's a mutual criteria where it's like, well, if you're going to enter this door, this is what you would need to know and consider about what you need to do to enter this space. So largely the drug user leadership, really the overarching findings was that leadership is, you can't do without it. It has to be there. Does anybody else on the team want to speak to that or anything related?
Yeah,
Yeah,
maybe. Oh, no, you go first, Phoenix.
So yeah, it was a community center model, really. It was like a neighborhood house or a community center that really focused on creating a space for drug users to be together, where they could use drugs and be drug users and not be kicked out or anything like that. And obviously, you know, knowing the drug user communities I do, there would obviously be issues with that. And a lot of it revolves around poverty. You know, if you have a house, people are going to want to live there because they have nowhere else to live. But you know, just addressing the need for space and community organizations to be involved. Like, I'm a proud member of the Dolphin Compassion Club, and it's really changed things for me, just being able to go there and use it as a space to meet people, and as well as a space to pick up what I need, and know that my concerns will be met. If I have problems, I can bring them up with the leadership, and it's really a club model that that is working really well.
Thanks, Phoenix. Jack, did you have a comment?
Yeah, Phoenix really said it mostly. I think the one other thing just to add is it's very connected to community building, but also relationship building was a really, really central desire of Safe Supply that we heard, and was really kind of essential to predicate all the rest of the findings. Was that first you need strong and lasting relationships, and this is really important because I think in a lot of Safe Supply findings and a lot of discussion around safe supply, people are not focusing on relationships. They're focusing on very clinical measures and outcomes. And what we really heard was you can't get to that point without the relationships. And so that's something that safe supply, in order to be effective, needs to deliver on.
Right. Was there anything in the presentation? I mean, I know probably a lot of this is not new, right? Stuff we've been hearing for a while. Was there anything that struck folks as interesting or significant or maybe new from what you heard, or anything you'd want to hear about more?
Sorry, just jumping in here. I really like the concept of a house and the less clinical aspect, because the reality is that is currently what is existing in community now for the most part. Is, you know, for folks who are able to be in those circles, right? And so it would be nice for everyone to have equitable access to what they need in a manner that's comfortable for them. Yeah, I really like the concept.
Mm-hmm. Thanks, Chanel. Cool. Since there's no burning questions right now, one thing we could maybe talk about for the research team is just the process, the method that we used, how we went about doing this, because since the interviews, we've been really hard at work, like full on. And it's been a while since we've had a chance to connect back with everybody. But if anybody has any comments about our community-based methods or what it was like working together as a team, because we have gotten feedback about that. So, Phoenix.
Yeah, so basically, Imagine Safe Supply taught me how to do research from the ground up, which has created a pathway to a full-time career, which is just incredible. I didn't know that I could do this as a high school dropout, be published in the Lancet, International Journal of Harm Reduction. Like it's been incredible to just work with a team that has taken the lived realities of drug users into consideration while building a team of incisive, keen researchers with different interests and skills who have brought this project to fruition. It's been incredible.
Amazing. Thanks, Phoenix. And Sean, I know you're working on the Slack there or on the chat there, but if you feel like pitching in here. Jack or Celine or anybody, Eric, I think Eric is on the call. Eric, a shout out. You want to give anything to say too?
Well, what I say is like, everybody have a role to play, and it's really interesting to see all the process. You know, it's like some people are good at, like, some people live they've been consuming drugs for a while. They know the reality. Some people care about it. They know how to put that into words and to document. And we need all this if we want to change stuff, you know. And it's cool to know that you get a lot of people like ready to help that thing, you know.
Yeah, it was definitely, I would say, a massive group effort. And speaking in line with what we heard in the research about the importance of leadership and relationship building, one thing in coordinating this work that I've seen is just everybody's skills over time just started to shine. And everybody had a very different skill set. And then everybody had a different role. And each one of those individual strengths became so important to being able to accomplish something. And one thing we talked about, because, you know, when conflict came up, conflict's never easy, but we need differences in order to do Safe Supply. We can't like get at this if everybody just is all getting along all you want to get along, but it's not like real. And to be able to work with the differences, because that means people have different life experiences. And if we can't reflect that in the work of designing this, of critiquing it and saying what we can dream of, then you're never going to make Safe Supply really speak to the actual needs that people have. So that was one of my big carry away is that leadership involves working with difference.
And maybe just to add as well that Phoenix mentioned about the training that was part of the process to make this research happen. But it was a real mutual learning experience for the entire team. I know personally the level of insight and the level of expertise that this whole team brought together was just really unparalleled. I feel so lucky, really honored to be part of this team. And it's not been a straightforward process, and I think really all good community engaged research is not straightforward. If you actually pay attention to the process, it's going to be complicated. It's going to probably take a lot longer than you initially planned it to, but these are problems that are part of the process. And Erin kind of alluded to some conflict, and that's also a necessary part of the research process. And yeah, it's just been a really great. I'm running out of superlatives, but it's been a really great experience, and it's been such a mutually reinforcing one as well.
Okay, I think my unmute button did work. Can you hear me?
Okay. Yeah, we can hear you, Mickey.
Okay, because I was just having a problem with it because that's why I couldn't answer you right away. It's like, wait, it muted me again. Okay, so as long as you can hear me, and that's good. Well, I mean, I got involved with this kind of last minute. I was referred to the project by a friend because I think someone couldn't, they went to one meeting and then realized they couldn't make the commitment. So I was just kind of brought on board in that way. And it has really helped sustain me, especially over the pandemic, because we've been doing this now for almost 3 years. And we thought it was going to be like a year. So as far as, well, again, like everyone else, I've learned so much. I have notebooks full of notes of things that, you know, I now want to look into and be involved in locally. And I've become pretty comfortable with the phone call thing because that's how I've been communicating is through my phone. We don't have internet and we don't have a computer. So it's been my trusty phone through the whole thing. Again, it's been really amazing, and to be part of it, and to especially this group. I mean, we've said it so many times. It's just so unusual for this kind of group to be a result of just getting together, and not really seemingly random people, but in some ways we're kind of random. And yeah, and also, you know, my sister, her death was drug related, and so for personal reasons, I really did want to be involved in this. And the deeper we got, I was just like, wow, okay, this is actually going to go somewhere. And it's just felt really, really good to be part of that. And I mean, I can't really go over everything I've learned because it's so much. Because when I started with this, I mean, talk about an absolute beginner. I really didn't know much. And sometimes it's hard for me to retain things, and that's why I take many, many notes. But I will read back over things and remind myself of the things that have come out of it for myself personally. It's been great.
Thanks, Mickey. Thank you. And just to say for folks out there, Phoenix, I'll come back to you, is if you're looking for experts in drug user-led community-based research, you know where to come. If you need people to help pitch in on your work, help you think through evaluation and research design, reach out to us, because there's a lot of capacity here. Phoenix, did you have a comment?
Yeah, just to further what both Erin and Mickey were saying, the way in which our skills were developed and shone through and were utilized was really personalized for each of us. Some of us were able to take on bigger roles in data collection and data analysis. Some of us are more adept at knowledge translation, and the barriers to technology that we've been facing trying to do this research during COVID and meeting virtually, and also meeting all across the country, has been just really smoothly handled and really well addressed. And I honestly didn't think that it would be possible to do this and to do this so well. So I just want to give the whole team a big round of applause. It's been wonderful.
Straight up. Thanks, Phoenix. All right, well, just one little last chance. If anybody here has anything else to add or any questions, we've got another 10 minutes or so. But if not, it's been a total and complete joy. And just for those of you who took part in this research, we want to let you know that we really took time with your words. And you know, I think we had multiple conversations about how absolutely incredible the conversations were. And we heard so many different perspectives from different parts of the country, but definitely some commonalities. So we want to thank you again. Okay. Well, I think that sounds like it's about it. If there's no other questions, we'll close. Feel free to reach us. And again, I'll be in touch in the upcoming weeks to share our website please use that and share broadly with your folks.
Thanks, y'all.
Bye.
Bye, everybody.